major things that he has found out in the discussions of these 2 days. Over to you, sir.
Well, thank you, Kiran. And I think since yesterday we have been discussing alternatively or in 2 parallel sessions about the PMJY and ABDM. While PMJY has become stabilized in some sense, that there is a well-defined, kind of process and hospitals and beneficiaries and rates, everything is defined. And we know the entire ecosystem of PMJY in some sense. The ABDM is still in an evolving phase. But I do feel that ABDM is, if we can do it well, this can be a really transformative, intervention in the healthcare delivery system. That's my personal belief. Aadhaar has been a transformational in terms of digital identity system, which has actually made service delivery so much efficient. So Aadhaar is a kind of horizontal public good which has made, because every service delivery needs authentication, needs identification, and therefore it's extremely important. And it can be now, as a digital identity can be plugged into everything. Similarly, the payment systems which we have developed as a country have also been extremely transformational. And now we are doing 7 billion payments per month in the UPI system. And that has also been, quite unique in the sense that countries have tried various payment systems, but they have not taken that revolutionary step of unbundling payment from the bank. So I think what is important is that in ABDM, we are not creating any monolithic structure. We are not creating an end-to-end flow of stuff. We are just creating building blocks which have open APIs, which have open standards, and which are open in many senses of the term. And they can be used to construct, like a Lego block can be used to construct a whole toy. Similarly, the building blocks can be used to construct whole solutions. So that is the architecture of Ayushman Bharat Digital Mission. Also, as I said yesterday, our role is not to create applications, the front-end applications, either from the hospital side. We are not creating HMIS. We are not creating the end-user applications. We are not creating Arogya Setu, for example, similar to Arogya Setu. We are just creating a framework, and that framework actually allows solutions to plug and play. Now that I think is a very scalable architecture. For example, CoWIN was a framework in some sense, but it allowed applications to just plug into it to essentially provide the care of vaccination to people. So similarly, we have created a framework, and now other ecosystem partners are developing applications. And as I said yesterday, there are 1,000 players who are actually integrating in our kind of sandbox. I want to repeat again that our purpose is not to make a monolithic structure of health delivery system in this country. We are going to promote diversity like we promote diversity in our country, whether it is a cultural diversity or food or whatever, dresses and languages. Similarly, this is all kind of disparate applications are fine, absolutely fine. We encourage them. The only condition which we want from them is that they must somehow enable interoperability. And that interoperability is enabled by certain APIs, which actually they must, ensure that they are able to allow a seamless flow of information from one application to another. What we typically call digital silos, those digital silos must be broken. And that is what we actually call ABDM compliant. When we say ABDM compliant, that means they are compliant to the protocol of the ABDM, the language of the ABDM. Like the UPI is a language of money transfer, ABDM you can describe as a language in the health space of health data transfer or health interactions and health service delivery. That is the architecture which we believe in. And that architecture has two advantages. One, the strategic role of providing a glue to every application is being played by the state in some sense. You know, we are creating that set of protocols, that set of architecture. And the other players, which are the private players, they are very good and very agile at developing applications. We don't develop great applications. You must have seen many of our applications. They are not very great. So we don't want to get into that space where we are not very efficient. But we are very efficient in scale. We are very efficient. We did Coven. I mean, I don't think there is any application which crossed 2 billion transactions in a year's time. So I think that's what we are good at. And we are basically creating those frameworks which are scalable, which are interoperable, which provide gateways for other applications to interact. That is our forte, and that's what we are doing. And that, I think, is similar to connecting the dots, because basically information technology is being used in the service delivery even today. Even today, you are calling your doctor on a mobile phone, on a video call, showing the symptoms to him or her, and you are using ICT in some sense. But it's all happening in a, for example, when the COVID happened, and then there were problem of the oxygen cylinders, there were WhatsApp groups which were being created. There were WhatsApp groups for creating whether beds are available or not. There were WhatsApp groups for remdesivir, this thing. But those things were not working because they were all in silos. But there is a similar program, CoWIN, which actually works across the nation. You did not create any kind of, scarcity of vaccines, or no black marketing of vaccine did not happen, only because it provided a very transparent way. So what we are doing is we are just collecting the dots, we are providing a framework, and now the house in some sense is ready, the framework is ready, but it all depends on the ecosystem partners, the doctors, the laboratories, the hospitals, the pharmacies, and the patients, and also the application providers, which are the health tech companies, to make this entire thing happen. And as we are always interacting, if there is a defect in the framework, we are always ready to change the framework. But then we don't want to get into a situation that we change the framework, you change the application, and then you change the application, we change that kind of thing is not good. So the framework should be a very robust, based on robust architecture and robust thinking. And that's what we try to do by having previous consultations with everybody. So my take on this is that the system can become extremely transformational, because it will be great for patients, it will be great for doctors, it will be great for hospitals, it will also be great for policy makers, so that they could have a data-driven policy making. So I think overall it's going to be an extremely beneficial system, number one. Number two, because we are in a sense, beginning on a clean slate, we will be able to provide a beautiful interoperable solutions. Countries like US and Europe, they are not able to do so because there are Cerners of the world. There are, what is the other company in US? There
Epic.
are two, Epic. They are the ones who are controlling the entire thing, and they don't allow this kind of, democratic flow of data. No entry barriers to the players. There are huge entry barriers once you develop monopolies. We are at that initial stage where monopolies have not developed in our health data market, and I think we are creating a very democratic way of this market making. So that's my sense, friend, that unless all of us play together and all of us consider this not as a problem of one entity or another entity, all of us will have to come together to make it happen.
Thank you, sir. Just as you said, sir, the house is ready, we need the guests to come in, or the road is ready, we need the cars to ply. We have Dr. Ambrish Mittal with us, representing the private sector, the one of the most important partners in this entire ecosystem. So we would like to take your views, sir, and how the way forward should be for the ABDM, the mission as such, to bring the private sector players and even other stakeholders together, and what you think are the expectations of these players.
Actually, I'm not really representing the private sector here. I'm very much part of PMJ, but nevertheless, yes, I have some exposure to that, so I can give my inputs. The issue here is as follows. If you're talking overall of implementation of Ayushman Bharat or PMJ, there has been a struggle, there has been a challenge to get the major private players involved. And we've discussed that so many times in our governing council meetings and personal meetings, etc. It is happening, but not the way perhaps all of us would want and like. And there are many challenges there, and I'm not going to go into detail. This has been discussed many times. Many of them pertain to, billing procedures, the release of payments, but that's logistics and that's beyond the scope. What I was thinking, and I gave a lot of thought, what will actually get private players into this, the larger private players who have huge reach actually. Nothing as compared to the government, of course, but the larger private players in India now have a big reach. The thing is that perhaps one of the things that could help as a constructive suggestion would be recognition of levels of specialization and utilization of particular specialty. And what I mean is that, for example, if Apollo is tying up or Max is tying up with PVGM, overall, huge, so many hospitals, 20 hospitals, 20, 30 hospitals, it may not be a blanket tie-up. It may be that for cough and cold and loose stools, maybe you need to go to a primary health care provider. It's maybe for tertiary and quaternary care, where the hospital has the skill and the capacity, which is not easily available everywhere. That is where we should tie up. So I think selective tie-ups for selective specialties, if they are feasible within our framework, will probably loosen up a lot of this sort of tightness or this rigidity in our partnerships. So, for example, maybe some group is tying up for cardiac surgery. They have a very high turnover, low cost model. Some group is tying up for knee replacements. So I'm talking of that, but it's not typical routine OPD stuff. Many of these larger chains will be reluctant to tie up. So my gut feeling is that while everything can be implemented once the government wants, of course we know that, but the fact is to get active and participation from leading private healthcare providers, it is important that we possibly consider partnering for selected specialties based on the bandwidth of that provider, based on the capacity of that provider. So I think that may be one area where we can break the ice with many larger chains. And I don't think, in principle, this is of course based on across the table conversation. In principle, no one is now against or reluctant to adopt the PMJ parameters. So I think it is just about which areas and where, and we can make a beginning by that. And it's all, everything can be changed. But to start off, perhaps that is one good point that I thought. That is in fact the main point in getting the private providers into this. I think that itself will make a difference. There are perpetual issues about pricing and about payment release that are discussed in so many committees. I don't want to go into that there. And I'm sure they are being looked into. So, as I said, this is my main point with regard to getting larger private healthcare providers into the overall ambit of PMJ. I think that will be a very good first step, and then we can extend it, depending on how it goes.
Thank you, sir. The WHO Digital Health Strategy is one of the documents that lays out a roadmap or a kind of a path for digitization of the health sector of different countries. And the ABDM has been following a strategy of taking everybody together and also building those digital public goods, which we say would be used not only within India, but also will be available for outside users, outside the country users as well. So I would like to hear from Ms. Payden as to how WHO views ABDM and where it sees ABDM to be going ahead in the next 2, 3, 4, 5 years or even 10 years, and how you think digitization of health sector in India would have an impact on the larger world.
Thank you. Thank you very much. First of all, I would like to thank Dr. Sharma for inviting WHO in this very important meeting. My colleagues Dr. Grace and Dr. Jaydev have been participating in the discourse since yesterday, and I understand from them that the sessions were very useful, especially in understanding what's going around in the entire country around PMJY and also ABDM. They could get a sense of what's happening, the progress that have been made so far, as well as trying to understand how WHO can play a better role and bring in added value in the implementation of ABDM as well as PMJY. So thank you for that. And now coming to the question, as you all would have heard, India had proposed a World Health Assembly resolution on digital health in 2018. So India had been discussing digital health for the past several years, and eventually World Health Assembly resolution on digital health was adopted by all the WHO member states in 2018. Following that, a global strategy on digital health was also proposed by member states and approved by the World Health Assembly in 2020. So basically it was the proactive role played by India in taking digital health forward in the entire world. Now the vision of the global digital health strategy is to improve health for everyone everywhere, ensuring that every person, no matter how rich, poor, or where the person lives, has access to equitable health services, all from prevention, promotive, rehabilitative to treatment. And that was the essence of the vision of the global digital health strategy. And I think it's the same premise that the Ayushman Bharat digital mission was also initiated last year. And on that, I also congratulate Dr. Sharma and the team for the first anniversary of ABDM. Now, India, as we all know, the size is really massive and diversity is really huge here. Digital health, as we have heard from Dr. Sharma, has a huge role to play in basically advancing access to health services, while also ensuring affordability, quality, equity, sustainability of the health services. So again, reaching health services to everywhere, and digital technologies play a very important role to ensure that the access is achieved. And again, coming back to Ayushman Bharat Digital Mission, the open source nature which Dr. Sharma was also highlighting, the platform provides cost-effective and scalable solutions, not for India, but also for the entire world. Other countries can learn from India, can adapt and adopt from ABDM to their national context. And there are many challenges and also opportunities which we have heard from Dr. Sharma, so I do not want to highlight on those. WHO remains committed to support the initiatives as well as taking the ABDM further in India, as well as sharing it with other countries in the region as well as globally. Over to you.
Thank you. Thank you. One of the speakers who's joined us today from Massachusetts, Boston, is the former additional CEO and the mission director of Ayushman Bharat Digital Mission, the person who's led this mission from its very beginning, who was instrumental in writing the cabinet note, all the policies we have today, and who paved the way for for that readiness, policy readiness that we are at currently. So I would like to ask Dr. Praveen Gedam to please give his comments now that he now has a bird's eye view of the overall system, and as to what he thinks are the roadblocks that ABDM should be looking at addressing in the next few years, and how he thinks our strategy should be changed or rather adapted in order to make sure that adoption picks up, and also to summarize what he thinks should be our major takeaways from this whole event that we've had. Over to you, sir.
Yeah, thanks, Kiran. The challenges in the area of digital health are generally well known in the healthcare ecosystem. Particularly from Indian point of view, there are challenges such as availability of infrastructure, that is hardware, software, and internet connectivity. But I think that's not a big enough challenge from my point of view, and we have sufficient infrastructure and obviously very good connectivity. The second challenge I can think of is of standards of interoperability. Health is a very peculiar subject. One doctor says a particular disease in a particular way, and another equally qualified doctor, he writes the same diagnosis in a different way. So there are multiple challenges of interoperability, but they are also solved. The biggest challenge in my opinion is of actual adoption. So when we talk about India, there is a doctor who sees 50 patients, 100 patients of OPD in a day, a nurse who takes care of hundreds of patients in a day. Where is the time to go and do data entry? So the challenges of adoption, challenges of adopting our behavior of a healthcare provider without compromising on the healthcare. And I think here the role of software developers, the HMIS developers come into play, and we should actively promote easy to use digital health solutions. And there are a number of ways this can be done. You really should not force a healthcare provider to do digital data entry for things which are not required. For example, in the United States, I saw tremendous amount of data entry which is required. We should focus on what is required for clinical use. Number two, there are several tools which can make use of software solutions very easy. Voice to text conversion, autocomplete, predictive text, and then configurability of the user interface. So these are the challenges which we see, which I have seen for 2 years in India, and these are challenges throughout the world. And I think we should go towards very easy to use, cloud-based, multi-tenant, easy to sign in, easy to switch from one system to other system without any vendor lock-in. These are the methods we can overcome these challenges, and that has been one of the important track of action in the National Health Authority while laying foundation for this ambitious mission.
Thank you, sir. Another thing is on the policy front, because we had our discussions on privacy and security, and you being having worked on the HDM policy and also the privacy policy and retention policy, you think there is anything further we need to add and how we need to adapt on that? We wanted to have your view on that as well, sir.
Okay. Talking about privacy and security, I want to assure the country that privacy and security is inbuilt in the design. It is in the design of policy of APDM, and it is in the design of digital or software solution of the APDM. So every single attempt has been made to ensure that the identity of person or the health related of information of a person is not made available to anyone except himself. The data is controlled by the patient or the data principal, and she or he only decides what data, for what proportion of data, and for what time it should be made available to the other person, including the other doctor as well. And the digital consent artifact ensures that this is actually done. And this has been done at all the levels. For example, the ABHA number, or earlier known as Health ID, it's a randomly generated number. It has no inbuilt intelligence like a PIN code or STD code. So all these elements have been considered And I just want, and last and most important thing, there is no data repository of centralized nature. We are not building any, we have not built any data hub. Whatever data is there, it used to be there in different hospitals. Hospital A's data with hospital A, national health programs data with national health program, and so on and so forth. It continues to remain at that stage. This is known as federated architecture, a decentralized system. What NHA has done is only developed connecting bridge between all these data sets, and the bridge gets activated only if the patient, after we verify his KYC, gives consent or a green signal that okay, I give consent that X amount of my data out of total Y amount can flow from A to B, and then only it flows. So it's a very secure and robust system. I want to assure everybody through this platform that data privacy and security is not the concern that they should be worried about.
Thank you, sir. So, having heard our experts for these 2 days and also the views of this panel, sir, I would now request the chair to kindly give his closing remarks and as to how he sees and what the big bold message that he would like to give on ABDM as to everybody who is participating and every stakeholder, so that we take it forward going ahead, sir.
Well, thank you very much. It's very difficult to really give a big, bold message, so to say. But one thing, Praveen also assured that one thing which we can assure is that the architecture or the framework which has been created is actually an extremely well thought out framework. And we are not going to change this framework frequently so as to cause inconvenience to our external partners who are there, who are linking with us. Even if we make changes, they will be internal changes, not visible to the outside, interfaces. So that's something which we can assure, so that there is a certain amount of certainty, in the architecture. Second thing which I would say, while there will be obviously, the stakeholders will have to work, the doctors, the other hospitals, the pharmacists, and everybody, and even the patients. I think one of the things which we need to do is to, show some value proposition. Think of, find out how this can benefit the individual persons. How can it benefit the patient? How can it benefit the doctors? How can it benefit the pharmacist or hospitals? I think that's what we have to think, because unless there is an incentive alignment, things will not work. This we have seen in a number of projects in the government in the past. Aadhaar happened because the kind of enrollment structure which was created was fully aligned with the interest of everybody. So the citizen was ready to get a digital identity free of cost. The government was ready to finance the enrollment and provision of that identity. And the enrollment agencies were being paid on the basis of how many enrollments they did. So they also were interested in maximizing their enrollment. Enrollment agencies were paying to their enrollment agents, the guys who are working in the field, on the basis of how many enrollments they did in a day. So everybody's interest was aligned. Everybody was working toward the same objective of maximizing their incentives, their, profits, or whatever you call it. Incentive is a better, sort of more agnostic word. Profit seems to be a bad one probably. Now what is happening is, let's think of what can be done. So for example, we have come out and on the basis of Ladakh, believe me, Ladakh is the one which, and I am sure some officer or somebody from Ladakh will be here in this audience. They got a prize also. Ladakh thought of this, scan and share. So what these guys did was that rather in a long line, where I go and just tell my name and my father's name and my age and my gender and my communication address, and the clerk at the thing is typing in the system, What they came up with was that, there is a QR code. That QR code has just the URL of that hospital, which basically the web address of the hospital. And that, you scan your QR code with your Aadhaar number, and the entire information, your profile information which is there in Aadhaar, which is your name, address, gender, etc., that is basically transmitted to the particular address, which goes to the HMIS of the hospital. And the hospital basically registers him automatically. So what this fellow people realize that by having Aadhaar number, I am able to evade the line. I don't have to go into the line. I can just, go scan the QR code and I am registered. If the OPD slip is being printed, in fact, you can even have the OPD, kind of like you print your boarding pass at the airport by just scanning your QR code, the ticket, and your boarding pass comes out of the kiosk which is there. Similarly, if there was a kiosk, people could go there, scan the QR code and get the OPD slip also taken out. So I think this is a minor, thing, but it is pretty major. In All India Institute of Medical Science, I have known people coming and getting into the line at 4 a.m., getting out of the line at 12, 8 hours, not getting the OPD slip, again getting a part of that same line next day. Now, this is actually, it's a very minor thing, but it can have. So what you do, similarly, when you are sharing the information with the doctor, you are sitting and the doctor is having a QR code, again specific to him. And you just show your Aadhaar ID and all your health record just gets transmitted to his system and he is able to see. So you are able to share. So without actually telling anybody, without getting it dictated, without getting it typed, if there is a beautiful way of digitally sharing your information, then even an illiterate person can do that. You don't require anything. You just goes and scans the QR code. And we are actually carrying out an experiment since last 2 weeks in Lady Hardinge's Medical College and Hospital. And there we are now giving about 200 people per day or 150 people we are serving. So they don't have to get on the line. There is a queue management system. 2 counters are there. Once they scan, they get a number. They get a token number. They keep on sitting quietly, and once that token number is displayed, they go there and just show the token number and immediately get the OPD card in 5 seconds. So the turnaround time at the line or at the counter has become 5 seconds from 5 minutes. So these are small benefits which I think we should think of. So all of you, many of you are creative people, creating applications, health techs. These are some of the things which, for example, one healthcare application provider has thought that if you scan your, diagnostic reports relating to, let's say, blood pressure, then it can show as to how your blood pressure, it can do a lot of analytics. Even the data can be read from those scanned papers, and they can create an analytics. So once you create some interesting value propositions, because nobody is going to adopt unless there is something in it for him. That's a universal law. Whether it's a financial incentive or whether it is some other incentive. I mean, people do charity, I understand, but generally, this charity is not sustainable, scalable. There are many issues there. So I think this is the best way to figure out, and that I think can be done because digital is actually the future. Digital way of doing things is the future of this entire, that's my view, and I have always held the view that digital technology adoption can solve many of India's hard problems. It's a great enabler, and I think we should go digital and therefore think of, just my suggestion, because we are grappling with this situation of adoption. I mean, imagine we have taken it to 1 crore in 5-6 days. These linking of records, that itself is showing that there is an interest, and there will be what is called a tipping point beyond which things will start automatically happening. But before that, you have to do a lot of work. So as Kiran was saying, the road is ready. Now we need to run the vehicles on that road. Thank you.
Thank you, sir. Your vision and your guidance and under your guidance, I think the systems we are building, we have proved the technology. I think adoption is the next problem that we'll crack, sir, with the support of everybody we here. So with that, we come to the close of this session. We have a few awards to be given away to some of the partners who have done excellent job in implementing ABDM, sir. So with your permission, we'll do the awards now. Start.
Thank you for the session. I'll be announcing the top performing states achieving maximum percentage and saturation in the population of public facilities in health facility registry in a period of 50 days by 19/9/2022. Lakshadweep, Dr. MP Bashir, Director of Health Services, kindly come on the stage to receive the award. I request CEO sir to kindly give the awards. Shri Randeep D from Karnataka, the Commissioner, Department of Health Services. Karnataka, Randeep sir, please. Next is Chhattisgarh. I request Shri R. Pasarana sir, Secretary Health, to kindly receive the award on behalf of Chhattisgarh. Next is Maharashtra. I request Shri Sanjay Sarvade, the Joint Director NHM, to kindly receive the award on behalf of Maharashtra. Andhra Pradesh, Shri G.S. Naveen Kumar sir, kindly, Special Secretary Health, are requested to please come on the stage for Andhra Pradesh. Next is Himachal Pradesh, Shri Subhashish Panda sir, Principal Secretary Health, Himachal Pradesh. Next is Ladakh, Dr. Iftikhar Ahmed Chaudhary sir, MD NHM and ABDM UT. Dadra and Nagar Haveli and Daman and Diu, Dr. Khushbu H. Rathod, kindly receive the award on behalf of DNSDD. Next is Sikkim, Dr. Madan M. Dhakal, SMD ABDM. Sorry. Next is Goa, Dr. Kedar Raikar, State Nodal Officer, ABDM. Uttar Pradesh, Dr. Manan Akhtar, Special Health Secretary, Uttar Pradesh. Next is Bihar, Shri Anshul Agarwal, Additional Chief Executive Officer and SMD ABDM. Bihar. The next state is Telangana, Shri Manjunath Nayak, CIO of ABDM. Telangana. Next state is Assam, Shri Rahul Dev Chakrabarti, State MIS Manager, is requested to kindly take the award. Next state is Meghalaya, Shri Ram Kumar, SMD Meghalaya. The last but not the least, Puducherry, Dr. Ramesh, SMD ABDM. Thank you, sir, and congratulations to all the states. I request CEO, sir, to kindly give a memento to Paden for. Thank you so much for joining us.
Thank you all. Thank you, Praveen sir. Thank you, Dr. Mithal. Thank you for joining us for this. We close this last session discussion for the day, and we will be starting our closing session now in the next 10 minutes. Honorable Minister would be joining us in a few minutes, so I request you all to continue be seated, and we'll just start in just a few minutes. Thank you so much.
Thank you very much indeed.